Can I
Like,
pause you for a second?
uh-huh.
Take your headphones off for a minute if you don't mind.
Yep.
Yeah, she's wrong on this one. Welcome back to the Think Like the Test podcast. I'm Ben Caldwell. With me again is Carrie Wita.
Hello.
And Carrie, you are on the path to become an MFT. Why did you choose MFT as opposed to social work or psychology or another kind of mental health career?
Well, I think originally I was looking into the psychologist license because that was the only one I really knew about. I didn't know that the other licenses existed. And in the course of, learning about that license, realized it takes a lot longer to get that license than to get one of the master's level licenses. Um, then I started trying to compare social work, marriage and family therapy, and counseling. And in California, I mean, there were seemed to be some very philosophical, theoretical differences that at that point, in my understanding, I could not tell, I could not parse what the difference was. What ultimately did it for me was that seeing that in California, I would get hours done during grad school, and then those would count towards the total that I need to get a license. And I wouldn't need to do anything extra to see couples, families, and kids. Where my understanding was at the time, and I believe this has changed in California, but at the time for counselors, in order to be able to do that, you had to like jump through some extra hoops. So I figured I'll
Correct.
do the MFT.
Makes good sense. We're going to talk a little bit more about some of those questions of why after we go through today's sample item.
Oh.
Are you ready for today's sample item?
Yes, ready to see where this goes.
A 19-year-old college student is referred to therapy by her physician for symptoms of panic. Her physician declined to prescribe medication until the client has initiated therapy. The client, however, believes that only medication will control her symptoms and that therapy is a, quote, waste of time. Which of the following interventions would a cognitive behavioral therapist use to address the client's participation in therapy? A, interpret the client's distorted cognitions and identify their connection to her current symptoms of panic. B, explore the client's disappointment with her physician and validate her automatic thoughts as a logical consequence. C, examine the client's assumptions regarding treatment and collaborate with her to promote a shift in personal conclusions. Or D, role play with the client to increase her assertiveness and encourage her to communicate her concerns directly with her physician.
Oh, wow. So this is
Yeah,
testing
there's
my
a lot here,
knowledge.
right? These are
Yeah.
long response options.
Yeah. Uh, this is really asking me how much I know about cognitive behavioral therapy, isn't it? What, which of the following interventions would a cognitive behavioral therapist use to address the client's participation in therapy? Okay. Well, let's just start with A. Interpret the client's distorted cognitions and identify their connection to her current symptoms of panic. Uh, I do know that that's part of CBT is identifying distorted cognitions or interpreting them. So that makes sense. That sounds like an actual CBT intervention. So um, could
Can I
like
pause you for a second?
uh-huh.
Take your headphones off for a minute if you don't mind.
Yep.
Yeah, she's wrong on this one. Okay, go ahead.
Okay. So yeah, I think that distorted cognitions are part of CBT. Um, identify their connection to her current symptoms of panic. Um, I think that might be jumping the gun a little bit. I think that might be fast forwarding a little bit because this question says that she's referred to therapy by her physician for symptoms of panic. Um, and her physician won't prescribe medication until she starts therapy. But the client believes that only medication will control her symptoms and that therapy is a waste of time. So if the client believes that the therapy is a waste of time and the therapist is jumping right into trying to use CBT to address the symptoms of panic, I don't think that they've gotten that the therapist hasn't gotten buy-in from the client yet. So I think that's like down the line a little bit. Um,
Okay.
so I think probably not A, but I'm not going to strike it out yet. B, explore the client's disappointment with her physician and validate her automatic thoughts as a logical consequence. Oh, okay. I'm pretty sure again, CBT, not my main, theoretical home as a clinician. So I think that that is all CBT stuff. Validating automatic thoughts as a logical consequence. That sounds like a CBT thing for sure.
It
Um,
sounds very CBT, no doubt.
it does. It sounds super CBT. I'm not sure how that has anything to do, like how that helps the client feel better about therapy or change the client's mind that therapy is a waste of time. Um,
Okay.
so I'm not feeling great about that one. C, examine the client's assumptions regarding treatment and collaborate with her to promote a shift in personal conclusions. So addresses addresses what I think needs to happen first, which is addressing the assumptions regarding treatment. The fact that this client straight up says therapy is a waste of time, but boy, this doesn't sound as CBT as the other ones. Because I think any approach would, well, that's no, yeah, I think many approaches would examine the client's assumptions regarding treatment, um, and collaborate with her uh, to do, this. I guess this does say to promote a shift in personal conclusions. Um, I suppose that that's probably more CBT than say narrative. But again, the first two sounded a lot more CBT. So I like that one, but I'm going to come back to it. Let's see. D is
Okay.
role play with the client to increase her assertiveness and encourage her to communicate her concerns directly with her physician. Oh, interesting. So, oh, in this one, it sounds like the therapist is like maybe honoring the client's wishes to not do therapy and maybe is trying to help the client go back to the physician and assert herself to, get the medication that she wants as opposed to doing therapy. Um, Surprising that a therapist would be trying to help a client not do therapy, but I suppose under certain circumstances that's probably very appropriate. Role playing with the client to increase assertiveness. I know that is definitely part of like assertiveness training. Can't remember if it's a real classic CBT intervention though. So where I find myself is I've got two answers that have very, very things I know to be specific CBT things. In answer A, distorted cognitions and their connection to current symptoms, super CBT. I know that is. But I feel like that's too soon to jump to that. B is validating automatic thoughts as a logical consequence. I'm also very confident that that's a CBT thing. But again, I'm not sure that addresses the client's initial issue, which is that she thinks therapy is a waste of time. You can't do therapy if the client thinks therapy is a waste of time, which makes C appealing to me. Examine the client's assumptions regarding treatment and collaborate with her to promote a shift in personal conclusions. Um, that starts where it does what I want it to do, which is start with the client's assertion that therapy is a waste of time. And I guess it's collaborating with her to promote a shift in personal conclusions, which means I guess shifting your, schema around therapy, your you know, uh, opinions about it, which is a cognitive thing, right? Shifting your thoughts. I'm gonna Yeah, and D is role playing to increase assertiveness. And I just can't imagine the answer to this question being helping the client get out of doing therapy. So I'm going to go with C. That's what I'm going to go with. Examine the client's assumptions regarding treatment and collaborate with her to promote a shift in personal conclusions.
So I'll tell you something. You got this right.
Oh, but like
I
for
don't
all the wrong reasons.
necessarily, well, I don't necessarily love the road you took, but I'll explain why. And just as a
Okay.
reminder to listeners, you're coming in cold. Like you haven't seen these questions prior to our recordings.
Right.
So I appreciate that you're showing us your thought process as we go here. I like that you keyed in on, okay, what's CBT here, right? Because you want to make sure that whatever the correct answer is, that it aligns with the theoretical orientation in the question. But that only gets you so far here. If you look at option A says, interpret the client's distorted cognitions and identify their connection to her current symptoms of panic. Well, it's really easy to key in there on distorted cognitions. That sounds very CBT and is very CBT. What is not very CBT is that word interpret. CBT clinicians do
Oh,
not interpret. They're not looking for the deeper meaning of distorted cognitions.
right.
They are just going to help identify them where they are. Interpretation is much more of like a psychodynamic or psychoanalytic
Yeah.
kind of thing. So you could rule A out on that basis and say, well, that one's not CBT because of that word interpret. Then
Interesting.
you get
Okay.
into B, C, and D, and all of those fit reasonably well into a CBT framework. There are terms there that align with CBT, but the actions also align with CBT. So just getting into what fits theoretically only gets you to eliminate A. What I think a lot of
Mm.
examinees don't focus on that you actually did, you kept coming back to this in a way that I really liked, that is a good illustration of a good habit on the exam. You kept coming back to, we want to address the client's participation in therapy, right? So it's not just the theory, it's what are we doing this for? And so, like on option D, you can have her communicate her concerns directly with her physician. But to what end? Are you wanting the physician to give her an out from therapy? Are you wanting the physician to further insist upon therapy when it sounds like the physician has been pretty insistent already? Communicating concerns directly with the physician, that is a good thing in life. You know, if there's
Yeah.
a dispute between a client and another provider, of course you're going to want to help them to address that directly. But specifically to address the client's participation in therapy, sending the
Yeah.
client back to the physician that they already have a problem with doesn't seem likely to get you very far.
Yeah.
And then you get to B and C. So B is explore the client's disappointment with her physician, validate her automatic thoughts as a logical consequence. Well, validation is wonderful and it's part of relationship building and it feels nice. And it would probably be good for the client to have that feeling of validation, connection with you as a clinician, but it doesn't actually address her participation in therapy. Only C does that. You're working to promote a shift in personal conclusions. You want to change her idea about therapy being a waste of time. So it's not just about, does this all fit within CBT? It's also about, what are we trying to accomplish?
Yeah. That makes a lot of sense. I'm gonna have
I
to
have
brush
no
up on
deeper
my CB.
analysis to offer here,
Yeah, no, that's it. That's very CBT of you. I, on the other
right?
hand, am going to have to come up. I'm going to have to brush up on my CBT. But yeah, that's really interesting. That makes a lot of sense now that you explain that. But it's definitely something that I totally glossed. Like I didn't even make like sure. I guess interpreting cognitive distortion. Sure, is that what you do with them? I don't know. But I should probably know that if I'm sitting for this exam.
Well, and certainly the verbs become important when you're looking at things like interpret. I actually don't love explore, just clinically, leaving aside test stuff for a second. I don't love explore as an intervention because explore just sounds like you're wandering around within something, like to what end?
Mhm.
And so when I have supervisees who are documenting their treatment, if they use explored blank as an intervention, I'll stop them and I'll say, wait. You need to actually put what you did that for. Like, what was the intention? What were you pursuing? But you will sometimes see explore on exam questions, and you shouldn't rule something out because it's explore. Just know that explore as a term is pretty vague, and it
Mhm.
tends to be used as an intervention. It wouldn't be a goal. So, like if you have a question that asks for goals of therapy, explore blank is maybe how you get somewhere, but it's not the destination. So that terminology kind of becomes important as you're going through here. You want to make sure that you have the knowledge based on the different theories so that you can identify terms that are consistent with the theory. But don't get so keyed in on that one aspect of the question that you lose track of the rest of what it's asking you for. If you'd like to learn more about this or the many other ways we can help get you ready for your licensing exam, please check us out at highpass.com. That's Highpass Education at highpass.com. Once again, for Kerry Weta, I am Ben Caldwell. Thank you for your time. Have a great day.